want you to picture a scenario that is, honestly, one of my biggest fears.
Okay.
You go to bed on a Tuesday night. You feel totally fine. You sleep for 8 hours. But when that alarm goes off Wednesday morning, you try to reach over to hit snooze, and your arm just won't move.
That's the classic terrifying presentation of the wake-up stroke.
Right. And the panic sets in. You get to the hospital, and the first thing they ask is, when did this start? And you have to say, I don't know, sometime. Sometime while I was asleep.
And for the longest time, that answer basically disqualified you from the best treatments, didn't it?
It did.
It did. It's what we call the time is brain dogma. In neurology, we have operated under a very strict stopwatch. The gold standard for dissolving a clot thrombolysis has a window of 4.5 hours.
So if you slept for 8 hours.
If you slept for 8 hours, in the eyes of the protocol, you are already too late.
Too late. That is such a heavy phrase to hear in an ER. But today, we are diving into a study that basically takes a sledgehammer to that stopwatch. We're talking about the OPTION trial.
A huge deal. This is a massive new piece of research out of China that really challenges the idea that the clock is the only thing that matters.
So it's asking a question that I guess has been bothering neurologists for a while.
For a decade. If we have a patient who is technically late, between 4.5 and 24 hours post-stroke, can we still save their brain using these powerful drugs, or is it just too dangerous?
So if you're listening and you have parents, or you just worry about your own health, this is huge.
Yeah.
We are moving from a world where doctors look at a clock to decide your fate.
To a world where they might look at something much more specific.
Exactly. We are shifting from chronological time to biological time.
And that shift is messy, I'm guessing.
It is. It's risky. And as this trial shows, it comes with some very, very serious trade-offs.
Okay, let's unpack this. The OPTION trial. Before we get into the results, which are genuinely surprising, we need to understand the players. We're talking about a specific drug and a specific type of stroke.
Let's start with the stroke itself. The study focused on non-large vessel occlusion. Acute ischemic stroke.
I know, it rolls right off the tongue, doesn't it?
It sounds like a legal disclaimer. Help us visualize this. What is a non-large vessel stroke?
So to understand that, you have to understand the brain's plumbing. Think of the blood vessels in your brain like a city's road network. You have the massive 8-lane interstate highways.
Okay.
Those are the large vessels. If a clot blocks one of those, it's catastrophic. It's a massive traffic jam.
And for those, you usually go in surgically, right? The mechanical thrombectomy I've heard about?
Essentially, yes. We snake a catheter up there and literally pull the clot out. But this trial wasn't about the highways.
It was about the secondary roads.
The boulevards, the main streets, the little cul-de-sacs, these are all smaller vessels.
And I assume you can't just snake a tube into a cul-de-sac as easily.
Exactly. The vessels are too small or they're too winding. Surgery is often way too risky or just, technically impossible.
So for these patients, if they missed the drug window, what happened to them?
They were often left with just aspirin and hope.
Aspirin and hope. That's not a great treatment plan.
It's supportive care, but it's not a cure. And that's the gap the OPTION trial tried to fill. They wanted to see if we could use a chemical clot buster, specifically Tenecteplase, to clear these side street blockages, even up to 24 hours late.
Tenecteplase. I feel like I'm seeing this name everywhere lately. Is it new?
It's the upgrade. The old standard was Alteplase, and Alteplase is great, but it requires a 1-hour IV drip. Tenecteplase is a bioengineered version that's more specific to clots, and, crucially, it has a longer half-life.
Which means?
It means we can give it as a single bolus.
A bolus.
Just a quick injection, push the plunger, 5 seconds, and you're done. It's faster, it's cleaner, easier for the nursing staff. But the question was always, is it safe to use it this late in the game?
So why is late so dangerous? I mean, if I have a headache, I can take ibuprofen 12 hours later and it's fine. Why is a clot buster different?
It's because of what happens to brain tissue when it dies. When a stroke happens, part of the brain dies almost instantly. That's the core.
Right.
But around that dead core, there is an area of tissue that is just starving. It's stunned, but it's still alive. We call that the penumbra.
Okay, stunned but alive. I get that.
But here's the problem. If you pump a powerful blood thinner into tissue that's already dead, the blood vessels there are necrotic. They're fragile. They're falling apart.
So if you restore high-pressure blood flow,
it doesn't heal. It bursts.
Oh, wow. So you turn a blockage into a bleed.
Precisely. And a bleed in the brain, an intracranial hemorrhage, is often much, much worse than the original stroke. So the fear has always been, if we treat late, Are we just causing bleeds in dead tissue without saving any function?
That makes the study design fascinating.
Mm.
Because they didn't just grab 566 people and inject them blindly. They used a filter.
The perfusion imaging. This is the real hero of the story.
I love this part. Explain perfusion imaging. How's it different from a regular CT scan?
A regular CT scan shows you structure, it shows you the road. Perfusion imaging shows you the traffic. It tracks the flow of blood in real time. It allows us to distinguish between that dead core and the stunned penumbra.
There was a gardening analogy I read.
Yes. Imagine a garden during a drought. You have some brown, crispy patches. That grass is dead. No amount of water will bring it back.
Oh, for good.
Right. But then you have the yellow, wilted patches. They look terrible, but they are still alive. If you water them right now, they turn green again.
So the perfusion scan finds the yellow grass.
Exactly. The option trial only enrolled patients who had a small amount of dead tissue, the brown grass, and a large amount of salvageable tissue, the yellow grass.
Which seems like common sense, but it's actually a huge technological leap to do that quickly in an emergency setting.
It is. It requires advanced software and, 24/7 availability.
So they found their patients, 566 people across 48 centers in China, all arriving between 4.5 and 24 hours late, all with salvageable tissue.
Right. And they randomized them. Half got the Tenecteplase, the injection, and the other half got standard medical treatment.
Which is mostly just.
Antiplatelets like aspirin, fluid management, things like that.
So the showdown. The aggressive drug versus the conservative approach. Let's talk about the results. Did the drug work?
The short answer? Yes. It worked significantly better than standard care.
Okay, define worked. What was the outcome they measured?
They looked at excellent functional outcome at 90 days. In stroke trials, we use something called the modified Rankin scale. A score of 0 or 1 means you have basically no symptoms. You can go back to work, you can drive, you are you again.
The outcome everyone wants. So what were the numbers?
In the Tenecteplase group, 43.6% of patients achieved that excellent outcome.
43.6%.
Okay.
And the standard group?
34.2%.
So 43.6% versus 34.2%. That's roughly a 10% absolute difference. Now, to play devil's advocate,
Yeah.
10% doesn't sound like a landslide.
In the world of chronic disease, maybe not. But in stroke, a 10% absolute increase is massive.
Really?
Think about the number needed to treat. This data suggests that for every 10 or 11 patients you treat with Tenecteplase, one extra person walks out of the hospital completely cured who otherwise would have been disabled.
Wow. When you put it that way, if I'm that one person, that 10% is everything.
It's the difference between needing a caregiver for the rest of your life and being independent. The p-value was 0.02, so this is statistically significant. It's not a fluke.
But there is always a but in medicine, isn't there?
There is.
We talked about the risk of bleeding, the exploding vessel problem.
We have to talk about the safety signal. This is the part that keeps doctors up at night.
So what did the trial find safety-wise?
They looked at symptomatic intracranial hemorrhage. That means a bleed inside the skull that's bad enough to make your symptoms worse.
Okay.
In the standard treatment group, the aspirin group, the rate was 0%.
0. Nobody bled.
Which makes sense. You aren't giving them a powerful clot buster. But in the Tenecteplase group, the rate was 2.8%.
2.8%. That sounds small, but compared to 0, it's a huge increase.
It is statistically very significant. The p-value is 0.004. So we know for a fact that giving this drug increases the risk of a bleed. You are introducing a hazard that just doesn't exist on the standard path.
And what about, the ultimate risk? Death. I saw the mortality numbers.
Yeah, we have to look at those. At 90 days, 5.0% of the patients who got Tenecteplase had died, compared to 3.2% in the standard group.
5% versus 3.2, that's nearly a 2% increase in death.
Now, hold on. We have to be really careful with the statistics here. The p-value for mortality was 0.28.
Remind us again, a p-value of 0.28 means what exactly?
It means we can't statistically prove that the drug caused those extra deaths. To say something is statistically significant and not just random noise, we usually need a p-value under 0.05.
So it could have just been bad luck.
It could have been bad luck. It could have been random chance. But if you are a patient or a family member and you see that number trending higher, it feels real.
It absolutely feels real.
And biologically, it makes sense. If you have a 2.8% rate of brain bleeds, some of those bleeds will be fatal. So even if the statistics don't prove it yet, clinically, we have to respect that signal.
So this brings us to the ultimate gamble. I want to role play this. Let's say I'm the doctor. You're the patient's family member. I've arrived 12 hours after my stroke. My scan shows I have that yellow grass, that salvageable tissue. What's the conversation?
The conversation is a trade-off, I would tell you. Look, we have a drug. If we give it, there's a roughly 10% better chance of walking out of here with no disability, getting your life back.
Okay, I like that. What's the catch?
The catch is there is a roughly 3% chance this drug will cause a bleed in the brain. And there is a small but real chance that bleed could be very serious or even fatal.
That is a terrifying choice to make in an emergency room.
It is, but you have to weigh it against the alternative. If we don't treat, you have a 66% chance of being left with some disability. And for many people living with severe disability, that's a fate they fear almost as much as death.
So you're betting a small risk of catastrophe against a high probability of disability.
Exactly. It's high stakes. But the option trial gives us the data to make that bet intelligently. Before this study, we were just guessing. Now, at least, we know the odds.
And the key to those odds is the imaging. I feel like we can't stress that enough. If you just gave this drug to everyone who walked in late without the scan,
it would be a disaster, an absolute disaster. You'd be treating the patients with the brown grass, the dead tissue.
So you'd get all the risk with none of the benefit.
Zero benefit, all of the bleeding risk. The success of this trial is 100% dependent on selecting the right patients with imaging.
This feels like it creates a new divide in healthcare, though. The haves and the have-nots of technology.
It does.
If my local community hospital doesn't have perfusion imaging software,
then they probably shouldn't be giving this treatment. This isn't something you can do with a stethoscope and a reflex hammer. It requires a sophisticated stroke center.
So let's wrap this up. The study was done in China, 48 centers. Does that matter? Can we apply these results to a patient in Chicago or Berlin?
It's a valid question. There are, genetic differences in how populations metabolize drugs, and stroke causes can vary. For example, hardening of the arteries inside the brain is more common in Asian populations.
So we need to be cautious.
Cautious, yes. But the biology of penumbra versus core, the yellow grass versus brown grass, that's universal human physiology. So while we'd love to see another trial, most experts believe these results are robust enough to influence guidelines globally.
It gives doctors a tool where the toolbox was empty before.
And it gives patients hope. That's the biggest thing. It changes the narrative from, sorry, you're too late, to, okay, let's take a look.
Let's take a look. That's a powerful shift.
It really is.
So, practically speaking, for our listeners, the takeaway: if I think I'm having a stroke, but it's been 10 hours.
Go immediately.
Don't self-triage.
Never self-triage. Do not look at the clock and say, oh, I missed the window, I'll just wait. You might be one of those people with great collateral flow. You might have salvageable tissue. But the only way to save it is to get to a hospital that can see it.
Removes the deadline for hope. I like that.
But keeps the respect for the risk.
Always respect the risk. Here's a final thought for you to chew on as we wrap up. We've spent all this time talking about a drug, Tenecteplase. But the more I listen to you, the more I think the drug is just a passenger. The vehicle is the imaging.
I think you're right. I think that's a perfect way to put it.
It makes me wonder, how many other diseases are we failing to treat because we're just blind? We throw drugs at huge populations like depression or Alzheimer's, and they fail in trials because maybe they only work on 20% of the people, but we can't see which 20% that is.
That is the frontier of precision medicine. We are moving away from blockbuster drugs that work for everyone and toward sniper diagnostics that find the specific patients who will benefit. The option trial is a perfect example of that. It didn't invent a new drug. It just found the right people to give it to.
It's not about the hammer. It's about knowing where the nail is.
That's a great way to put it.
Well, this has been a true deep dive. We went from the panic of a wake-up stroke to the nuance of perfusion imaging. It's complex, it's risky, but ultimately it's progress.
It is. And every bit of progress means more time for someone with their family.
Thanks for breaking it down with us. To our listeners, stay curious, take care of your brains, and we'll see you on the next deep dive.